I'm here to talk about harm reduction in the context of HIV prevention, treatment, care, and support for people who use drugs. And before we proceed, let's just focus on the theoretical case for today. We have a man who has sex with men as our client who is HIV positive as of March 28, 2017, visited your HIV. He started presenting signs of, oh my God, he started presenting signs of intoxication, drug intoxication. And he confessed to you that he has been engaged in PNP. PNP is a slang for party and play or sexualized drug use in the Philippines. He has been doing it for 6 years now. He admitted to have slammed last night. Slamming is the slang word for injecting of drugs. And upon your physical assessment, you found that there are multiple scars on both antecubital area and presenting signs of drug intoxication. So what are your immediate interventions, and will you report the client to authorities? How do you provide brief intervention to the client after the effects of the drug have subsided? And with this, let me just present the objectives for our discussion today. First, we need to understand the current situation of HIV and drug use in the Philippines, and understand the association between drug use and HIV transmission, determining the core interventions of stimulant users. And lastly, hopefully this will be the most helpful part of our topic, to know the different practical guidelines for immediate management of HIV and drug use in our country. So just to be clear, substance abuse is the excessive, harmful, or hazardous use of psychoactive substances. The main presenting sign or presenting symptom of this is the inability of the person to control his impulses of using drugs, leading to a cluster of behavioral, cognitive, or physiological phenomena that develop after repeated substance use. So just to be clear, substance use is different from substance abuse. And for us to know the difference between the two, substance use do not present alteration in the activities of the person's daily living, while substance abuse alters the cognitive capacity or the behavioral capacity of our clients. I hope that it's clear by now. And moving forward, we all know already, it has been constantly repeated in our class that the Philippines has the fastest growing HIV epidemic in the Southeast Asia. What I wanted to focus more on would be the discussion that we had during the health sector planning with the Department of Health. And the Epidemiology Bureau mentioned that there is a large number, or there are a large number of estimated HIV positive individuals who are not on ART, and this could infect other individuals. This gives us an insight that we need to intensify our HIV testing and treatment, and also, most importantly, retention to care. Because as of the moment, based on the data, we have 17% who were lost to follow up in the last year. And one possible gap in our HIV prevention and treatment cascade would be among those people sharing infected needles. Based on the August HARP report, there were only 13 diagnosed with HIV among people who were sharing infected needles. This gives us a very valuable information that we need to widen our reach among people who inject drugs and people who are using drugs in general. And that's the reason why DOH recommended that we need to increase our safe injecting practices among our clients from 40% to 80% in the next 2 years. However, here in the Philippines, we have very limited data among our people who use drugs. And most people who use drugs are not comfortable in accessing services in our healthcare facilities. And this makes HIV prevention and treatment somewhat a challenging task for all of us healthcare providers. Now, in Southeast Asia, in contrast to the worldwide report. The worldwide report, according to UNODC in 2016, cannabis or marijuana is the most commonly used drugs. But here in Southeast Asia, particularly in the Philippines, amphetamine-type stimulants are the most common. And this includes methamphetamine. Perhaps maybe, maybe because it is more affordable, and that's the reason why it is commonly used by our clients here who are using drugs. Now, in our local study done in UNODC Philippines in partnership with UNAIDS and a collaborative project with SHIP and Brown University School of Public Health, we found out that among the 491 survey online participants, 25.7% have experienced using drugs at least once in their lifetime. And among the 126, there were 90 who experienced sexualized drug use or chemsex. And from this 90, almost half are actively involved in chemsex, which brings us to one of the potential problems that we need to widen our reach and start discussing about chemsex in our healthcare facilities. Now, we all know what is the relationship between drug use and HIV and STIs, right? But this is further validated by our local study, and that's what you'll see in our cross-tabulation. Those who have engaged in drug use and those who have engaged in chemsex are more likely to be HIV positive than those who are not. And ironically, the frequency of doctor's visit here in the lowermost part of the table, a lot of our clients have never, a lot of people who might be using drugs may not be accessing healthcare services in the country, which brings us again to the main core of the idea that we need to start making our healthcare facilities a safer place for people engaged in chemsex. Now, the summary of findings included the following. I'm not gonna really dwell on this. It's just that it has proven and established the fact that there is indeed a strong link between chemsex and HIV and other STIs. And one thing that I would like to emphasize as a good news, though, is that here in the lowermost part of our bullet, we have 8 in 10 HIV positive men who have sex with men reported to have high adherence rate to ARV. This is a good news, but in a different side of the spectrum, 9 out of 10 HIV negative men who have sex with men reported to have not been accessing PrEP. I think this coincides with the advocacy of one of the advocacies of SHIP and also with UNODC and pretty much everyone else in the advocacy world, that we need to upscale and make PrEP a nationwide intervention, not only for people who are engaged in chemsex, but also for other people who need PrEP. Moving forward, approximately 9 in 10 men who have sex with men had no idea where to access health services for chemsex and drug use. And it is again going to pivot back to the main theme that I have been emphasizing in the last few minutes, that we need to start talking about this in our healthcare facilities, making our treatment facilities a more safer place to discuss all of these uncomfortable topics. Now, moving forward to the HIV prevention and treatment program for people who use drugs, let me begin by presenting this technical guide that UNODC has developed together with World Health Organization and UNAIDS, focusing on HIV prevention, treatment, care, and support for people who use stimulant drugs. Why am I emphasizing this? As what we have mentioned a while ago, stimulant drugs are more popular here in the Philippines. Then this might be a very useful tool for healthcare practitioners to use. And as what you can see, there is a QR code that you can scan, or the link in the uppermost part of the title, so that you can download it later on when Radnir begins to upload this in the SHIP website. All right. As of the moment, I would just like to focus more on the 8 core interventions of this prevention and treatment guidelines. One of which is the intensified condoms, lubricants, and safer sex programs among stimulant users. And this goes back to our general population advocacy of improving our condom access. As of the moment, men who have sex with men there are only 38%, I guess, if I'm not mistaken, 38% who have been using condoms or accessing condom, and we need to upscale that to prevent the spread of HIV infection. Second is a very controversial topic, which is the needle and syringe programs. Contrary to what other people may have believed in the past, harm reduction is not only NSP. It is a combination of multiple interventions. I would just like to emphasize that for the sake of clarity and moving forward, improving our HIV testing services, antiretroviral therapy, and I would just like to interject here that in our ART intake, adherence counseling is also very important. And also, I would just like to add the importance of non-occupational risk post-exposure prophylaxis and pre-exposure prophylaxis as part of a preventive program. Evidence-based psychosocial interventions and drug dependence treatment programs. Now, currently in the UNODC, the agency has started rolling out several programs with the community at the community level during the in partnership with Barangay Anti-Drug Abuse Council, City Anti-Drug Abuse Council, jails, prisons. So these are all drug dependence treatment and intervention. Evidence-based psychosocial intervention may be a fancy word for motivational interviewing. And if I'm not mistaken, I think Ivy, who discussed mental health before, already mentioned the OARS approach, the open-ended questioning, affirmation, reflective statements, and summarizing as part of this psychosocial intervention. What I am going to focus more on in this discussion is the brief intervention. Moving forward, we must also include in the discussion the prevention and diagnosis and treatment of STIs, hepatitis, and tuberculosis. And for that reason, we have Dr. Tripon to discuss later on hepatitis as part of our discussion. We have the second to the last is the targeted information, education, and communication for people who use stimulant drugs and their sexual partner. And lastly, prevention and management of overdose and acute intoxication, which brings me to the important hotline of intoxication and overdose prevention in our country. You may call the National Poison Management and Control Center. This is an open, a 24 hours facility that you may endorse your clients to if ever you receive a client who is experiencing overdose or intoxication. And as a quick overview, I'm not really going to dwell so much on this. It would take a lot of time, as I'm only given 20 minutes. One thing that I would just like to emphasize, though, is that we need to understand the different risk reduction and first aid interventions for the most common drugs or recreational drugs that our patient people who use drugs are taking, right? And among the different types of ARVs that we have in the country, only ritonavir has provided evidence to be potentially interacting with methamphetamine, and it increases amphetamine levels in the bloodstream 2 to 3 times higher. And poppers is a carpet cleaner, but it is used by MSMs during chemsex as a form of drugs that enhances their sexual experience. But one of the many effects of it is the thinning of the anal lining that may lead to anal bleeding later on. But on the good news, it has no known interaction with most of our ARVs here in the Philippines. And one thing that we need to emphasize, though, is that we need to tell our clients that if they are using poppers, always wear condom to prevent transmission of STIs and HIV. And it is contraindicated for people diagnosed with glaucoma. And that's it. Now, part of our pre-test question was that what do you need to do in order to prevent overdose? We are not talking about providing intervention to overdose. because if we provide intervention, then we may prescribe anxiolytics. But then, since me, for example, I'm a nurse, I'm not allowed to do so. The safest intervention to do is to tell our clients to increase oral fluid intake, and that would facilitate a faster flushing of the drugs out of the system. That is a very basic first aid guide for all of us before endorsing our client to more specializing practitioners. And with that, let me forward with a drug-to-drug interaction app. You may download this in your phone. It is a Liverpool HIV eye chart, but I'm not going to really dwell on this. It's just that it is a very helpful application on your mobile phone that would give you an idea whether two drugs are having potential interactions. Now, moving forward, this is the most valuable knowledge, should I say, that I could share to everyone, is the screening of drug use severity. It started off with our project at SHIP before in 2017. We have been using the screening tool to help healthcare practitioners to better assess the needs of our clients who might be using drugs. But in addition, we also have mental health gap that will give us a very valuable tool in determining the signs and symptoms of drug use disorders. I'm not really going to dwell on this. One thing that we need to know about this is that it can be used by community practitioners. You don't need to be a specialist to be able to understand this. All you have to do is just to maybe undergo a training with the Department of Health. This is provided, I guess, if I'm not mistaken, once or twice every year. I don't know if it's still ongoing. But anyway, moving forward, the for parental neurological conditions, including drug use, and another thing that is going to be the very convenient screening tool for all of us to use is the universal pre-screen. If you are a social worker, if you are a case manager, whoever you may be in the community or in the HIV facility, you may use this simply by asking your client, how many times in the past have you had 5 or more drinks in one day? Now, to be clear, 5 or more drinks in one day, one drink is equivalent to 1 bottle of Red Horse, for example. So 5 bottles of Red Horse is equivalent to this question. So how many 5 bottles of Red Horse per day have you had in the last year? If the patient answered, well, usually in one day, I would finish like 12 bottles of beer, then you may check 1 or more in this assessment tool. If you have checked this, then it gives you an idea that the client may be at risk for alcohol use disorder. It's not a confirmation test yet. And this will give you an idea to move forward to an additional screening of alcohol use disorder identification test. For drugs, the basic question here is that in the last year, well, in my case, I would adopt this into a more short period of time, a shorter period of time, which is in the last 6 months. So I would ask some of the clients, especially those who are reaching out to me in social media and Twitter, I would ask them, in the last 6 months, have you used recreational drugs or used a prescription medication for non-medical reasons? The main difference is that recreational drugs would be more on methamphetamines and prescription medication for non-medical reasons. This includes anxiolytics, but it was not really intended for anxiety, but more on the addiction side of it. Now, if the answer is yes, then we have to check this, and it will move us forward to several tests. We can use SBERT algorithm. We can use the DUDIT screening test. All the questions are here. Although DUDIT is very convenient, but it may be a little bit obsolete. It was released by APA in 2014, if I'm not mistaken. So you just have to score down the client based on his response. If the score is 6 or less, then that is just low risk for men. If it's 3 points or less, then it is low risk for women. But if it is 6 to 25, then there can be a low risk to moderate risk. that will give us an idea that maybe we need to do brief intervention and motivational interviewing for this client. Kanina, when the answer is yes, I've had 5 drinks or more, then you proceed with the alcohol screening. So this is still another scoring system. One thing that I really wanted to really focus on are the main goals here are divided into 4. Brief intervention is divided into first, second is to educate the client about his drugs and the drugs that are being used by the client. And number 3 goal is to enhance the motivation to change behavior. And number 4 is to negotiate and give advice on how to, move forward towards sobriety. And I would just like to emphasize that not all people are ready to be sober and be abstinent from drugs. And we should not impose a cold turkey approach. That's why we have brief intervention. We start off by asking, hey, patient, you mentioned a while ago that you were engaged in PNP, and you mentioned a while ago that you were using methamphetamine. So I would just like to find out, I'm really curious about what do you enjoy the most in using methamphetamine while having sex? So in this way, we are guiding our client to determine that there is a difference, all right, between his behavior and what is ideal. Moving forward, I guess the basic rule here, just to wrap things up, is to avoid telling them what to do, understand where the drugs are, listen, empathy, empower them, meaning that you make them set their own goals and you have to adjust yourself. This is not about us as healthcare practitioners, it's more about what they can do for the moment. And in summary, the last part of our discussion, HIV programs for people who use drugs should be intensified in the Philippines. There should be a safer environment for us healthcare practitioners, for our people who use drugs. Harm reduction, such as NSP, is an effective HIV prevention approach, and people HIV who use drugs should be educated on safer drug use, and that would come after establishing a trusting relationship, which is always the first step. And with that, thank you so much for listening. That ends my discussion on harm reduction.